And for those normal diffusion but long P2 tissue, the signal won't be affected, so it will looks relatively stronger than the lesion. This is a summary of the result. We want to use DWI to detect the lesion because it's brighter than the normal tissue. Meanwhile, it can detect the tissue with long P2 as well, so this is called T2 shine-through artifact or T2 shine-through effect. Then we use the ADC. The lesion will have a decreased ADC value, but those long P2 tissue won't have a decreased ADC value. In this way, we can eliminate the false alarm from T2 shine-through. T2 shine-through actually may happen in several cases. One is normal tissue with long T2, or cystic lesion, or hemangioma. This is an example. This is DWI with B factor set to be 500. It looks bright. A lesion is detected. And in ADC, if it's dark, then it's the true diffusion restricting lesion. In this case, it's a liver metastasis. And here, the renal cyst or gallbladder, they look both bright in DWI and ADC. So it's a T2 shine-through artifact. Here, those things, they're hemangioma. They look very bright in the DWI with B set to be 600. This is a parent T2 shine-through effect. And those big ones, they look a little bit, they seem to be brighter in the DWI, but it's not as bright as without those diffusion gradient. So it's a slight T2 shine-through effect.
Well, I'm sorry, you said the operator, the MR tech can choose the B value, right? And
yes.
That has to do with the gradient and the big delta and the small delta. And then, so when they give us these in a sequence, like how are we supposed to, like, when it goes from B0 to B150, does that mean that the gradient was decreased? There was less gradient applied on that sequence?
No, B0 means no gradient.
No, okay.
And
so B150 means there was some gradient.
Yeah, the B factor is set to be this small number, so there will be some gradient. And here they use a larger B, that means the gradient is stronger or longer, or long time to dephase. So the signal will decay, but contrast will increase. In hemangioma, here are two cases. So different hemangioma have different shine-through. Some are very apparent, and some might be slight. Now, we want to discuss how to choose a B factor. As we say, a large B factor will lead to a decreased signal intensity, but the contrast will be getting better. And here is an example using a small B and a large B. Those blue color means the lesion, restricted diffusion lesion. And if we use a small B, the signal intensity is high compared with this one. So it's better for detection with a stronger signal. But here, if we use a larger B value, the contrast is more obvious. So it's better for characterization.
And that's going to be contrast between lesions that restrict and don't restrict?
Most lesions are restricted, diffusion restricted, but they restrict to different degree. Okay. Some are severely restricted, some are slightly restricted.
So it helps me tease out which ones are very restricted versus not.
Oh, yeah. So according to the level of diffusion, according to the extent of restricted diffusion, you can characterize which type of lesion or tumor it is. So this one, we talk about the influence of B factor on the DWI image. So in the DWI, the signal decrease and contrast increase. It also has an effect on the ADC map. So here we want to illustrate. If we want to get an ADC map, we need image without gradient, without diffusion gradient, and an image with gradient. And this one, you can choose different B value. You can choose a small B value, maybe 200, and you can choose a big B value, maybe 1000. So how we want to rearrange this equation and get this equation. These two are mathematically exactly the equivalent or the same thing, just rearrange it. Notice that this is actually a linear function, y equals kx plus b. So this x corresponds to this b. Here, this b is the x-axis, and y is the log s. When we get signal intensity, we take a log and put it here. So y equals kx, then what's this k? It's the slope of the linear function. This is its d value. So the d value here, or the ADC, apparent diffusion coefficient, is the slope of this curve. As long as we have 2 points, one is S0, then another b value, we can get a line, and this line, the slope of the curve or slope of the line is the ADC we want to measure. And using a large p-value might help to improve the accuracy of ADC value. Suppose we choose S0 here and S here, then we draw a line. This ADC, the slope of this line is relatively stable. But if we choose a very small number of b, a small value of b, then this slope might be quite far away from the average value. So this means if we choose a larger b value, the ADC map might have better accuracy. Then we want to look at the specific application in liver. In liver, we may choose a small b value. This small b value lead to a stronger signal in the DWI image, so it's better for the detection of lesion. Alternatively, we can use a larger b value, which is maybe above 500 and below 1000. This larger value, b value, will lead to better contrast in the DWI. So it's better for the characterization of different type of lesions. And also the ADC map can have better accuracy with a larger b value. But in the liver, T2 is pretty short, so we cannot use a too big value, too big b value. If the b is too big, then the signal will decay too fast, and in combination with this T2 decay, so the signal attenuation will be significant. Now, after introducing how to design the pulse sequence and how to choose the b value and how to compare the DWI and ADC, we want to actually look at some application in liver. In liver, there are different types of application. The first type is detection and characterization of lesion. The second is detection or prediction of treatment response. And another type of application is the quantification of degree of fibrosis in liver. Before we go into details, we want to understand why DWI can be used to detect lesions. Lesions, they have restricted diffusion. So this is ADC or diffusion or diffusivity. Lesions have restricted diffusion. So those ADC value for the lesion is relatively lower than the normal tissue. This is normal tissue. This is lower, so it looks dark. And the DWI image is the opposite as ADC. So for the lesion, DWI are brighter than the normal tissue. And more specifically, if we want to differentiate lesions into different categories, if it is more cystic or necrotic, then it has better diffusivity relative to those solid metastatic lesion. It can move more freely, so here it's brighter than this one, and in the DWI it's the opposite. Then in hemangioma, which has T2 shine through effect because it has long T2, then the both DWI and ADC, they are bright. Okay. In DWI, the lesion can be identified from normal tissue. The contrast is high. And in the DWI, both the blood and the fat signal can be suppressed. Because the blood has high diffusivity, high diffusivity will look dark in the DWI image. And fat, it has very short T2. And short T2, because DWI is also T2 weighted, so short T2, they will have very low signal in the DWI image. Both blood and fat can be suppressed. Then this DWI image will be especially good for small lesion detection. We'll show in a few examples. Compared with DWI and T2, DWI is better to detect metastasis or hemangioma. Come back to this page. Because hemangioma and solid metastasis, they are very bright in the DWI, so it's better to detect it in DWI. But in cystic lesion, it's not too bright in DWI. It's better to detect it in T2. But from clinical point of view, this is what metastasis is what we are more interested. So DWI perform better. And DWI perform also better than the contrast-enhanced MRI. But combination of DWI and contrast-enhanced MRI may improve the diagnostic accuracy. We see some example. This is an example of neuroendocrine liver metastasis. They can be detected. They can be detected in DWI images. This is without gradient, and this is with gradient. It's easier to detect it in this DWI. And in the ADC, this looks dark. In ADC, it's dark, and in DWI, it's bright. So this is actually diffusion-restricted lesion, neuroendocrine liver metastasis. Here are colorectal liver metastasis of small size. It's easier to detect it in the DWI with B factor said to be 100 than in the T2 weighted images. Because in T2, there are many small vascular that look like that can be easily confused with lesion. And here, in the DWI, those vessels are suppressed, so lesions stand out. Here are metastatic carcinoid tumor. In the T2 images, they can be seen, but in the DWI, it's more obvious, and it's confirmed in the ADC, they look dark, so it's diffusion-restricted lesion, and in this case, the carcinoid tumor. Again, in DWI, it's easy to detect those small lesions, but in the contrast-enhanced image, they can easily be confused with other stuff. Similar example. So after detect of liver lesion, we can characterize. Here are the study of conducted by different group, one group, another group. If we just look at maybe one group, ADC value for different type of tumors are different. Normal tissue, they have this range or this average, but metastasis, HCC, hemangioma, cystic, and different type of lesions, they have different range for ADC value. So we can measure their ADC value and roughly get an idea what type of lesion it is. Now, more recently, the application of DWI has been extended to cancer management. It can be used to measure the treatment response by comparing the diffusion change, or it can be used to predict the treatment response with the baseline diffusion. Diffusion can be correlated with tumor size change or RECIST criteria. It can be also correlated with histology information, such as the percentage of necrosis, and it can also be related with recurrence. This is a breast tumor, actually. Then within this tumor, there are area, it's necrotic area. In the DWI, it's bright, that means it's diffusion restricted, it's a tumor. But in the center, because it's necrotic, it's liquid, so the diffusivity is increased and it looks dark. If you use an ADC confirm this, this means high diffusivity, and it's necrotic, and the boundary is diffusion restricted. But if we just look at the post-contrast, then this part is dark, and that means it's necrotic. We can use the DWI to predict the treatment response to chemotherapy. After study, people find out that if it's non-responder, usually the pre-treatment DWI ADC value is high, and the responder, they have relatively low ADC value. This is the post-treatment change. If after treatment the ADC value increased, and that means the diffusion restricting condition is relaxed, then it's more likely to be a responder. In the non-responder group, there is not ADC increase. Here is chemoembolization treatment response detection. They plot the same area before the treatment and after the treatment and compare. If the larger area, they have increased ADC value, then it's a responding case. In this case, it's partial response. And if most part ADC value is not changed much, change beyond the preset value, then probably it's a non-responding case. In this, here it's a progressive disease. With more patients, 48 patients and 71 HCC, people find out that the ADC change differs significantly for different groups. For partial response, steady disease, or progressive disease, the ADC value are different.
They're only looking at the baseline scan?
No, I think this is the change.
From baseline to 1 month?
Yeah, from baseline to 1 month.
Okay.
So the change predicts a 6-month response?
Oh, yeah.
Is that a similar time frame on the previous slide, where they showed the red and the green?
Oh, yeah, here.
So you do a scan 1 month after TACE, and you look at the early change, and the early change in ADC predicts a 6-month response? Is that what they did?
Yeah.
Okay.
So actually, these two, they have the same reference. So it's the same paper. Here, they just have the images for one particular representative responding case and one representative example of non-responding case. And if you calculate all these patients, and we find out the change, the increase in ADC at 1 month, they are significantly different between different groups. And also, they can correlate with 6 months change. Here is another study. Then they just measure after the treatment, the ADC value changes. They didn't correlate the change with other RECIST criteria. We finished the DWI application in liver, and now we turn to the DWI application in brain. Brain is a major part, body part, the DWI is applied. We can use DWI to detect lesion and also differentiate different type of lesion. It might be hard to characterize because there are too many types of brain tumor, but we can at least differentiate sometimes. And we can differentiate tumor residue from post-treatment change, see if it's recurrence or just a post-treatment change. And again, we can use it to detect early treatment response or predict the treatment response. Here, because the lesion type are too many, so we didn't divide them. We just call them diffusion restricting lesion and T2 shine through and normal diffusion. Those lesions, they are restricted, diffusion restricted, so it looks dark in the ADC value and it looks bright in the DWI. And so we want to detect using DWI. And in order to differentiate from T2 shine through, we look at ADC value. Same concept. Here is an example of stroke. These images are acquired at Robert Wood Johnson from, I got it from Mina. In CT, we cannot see any abnormality, but in MRI, this part, this is DWI images. It looks bright because the diffusion is restricted. So stroke is detected at very early stage, maybe just 1 hour after it happens. In contrast, in CT, they cannot be detected until several days later. Stroke is most famous application of DWI, but there are other brain lesions that have the restricted diffusion, like hemorrhage, trauma, infection, demyelinating, and cancer, and other issues. Mina have many exciting images, but due to the time constraint, I just skip them. Except detection, DWI can be used to differentiate extraaxial masses. For example, there are 2 types of tumor. One is epidermoid tumor, the other is some cyst. They both look dark in T1 weighted image and bright in T2 weighted image. So without diffusion, they have similar appearance and hard to differentiate. But since this tumor, the epidermoid tumor, is solid, so the diffusion is restricted. It looks bright in DWI, and this cystic lesion, they are more like fluid, so they look dark, relatively dark. It looks relatively dark than this tumor, but more brighter than the normal tissue. And also after the resection, there is cavity. It will full of CSF, so it won't look too bright in the DWI. But if it's tumor, and especially solid tumor, then the tumor residue will look very bright in the DWI. So in this way, we can differentiate whether it's residue or just the post-treatment change. Then in the brain tumor or intraaxial tumor, we can differentiate tumor from normal tissue, and we can also differentiate tumor from necrosis. Their ADC value are different. In some study, people investigate whether tumor can be differentiated from edema. This is of clinical importance, because if we know it's edema, then we can determine the radiation port or the surgery margin or biopsy sites. In some studies, they show that the ADC of enhancing tumor is less than the ADC of edema, but other studies show the opposite result. And it's important to know that the tumor has lower anisotropy than the edema, because edema, they have intact myelin. And similarly, post-treatment change can be differentiated from tumor.
Well, I'm sorry, you said that edema, a tumor has restricted diffusion beyond edema. Is that what you were trying to say? What you were saying in this last line? Or the second to last line?
I think edema, they have intact myelin. So.
So it will restrict more.
So yeah, it's
Okay.
more. It has more
It'll
direction.
be brighter on diffusion.
Yeah, not brighter, but it has more direction.
Oh.
So
for
it's
DTI.
Yeah, this is actually DTI. That's why we want to introduce the DTI, because this one has they want to, the structure is not broken, so it prefer to diffuse along the axon. Then the anisotropy is greater, and here tumor, maybe some structure is breaked, so it diffuse in different directions. The anisotropy is not that severe, or that apparent than the edema. DTI. Here are the DWI image. B is in X direction and Y direction and Z direction. We can see that they are different. These three are different. That means the diffusion or the motion happens not in one direction, but they can diffuse in X or Y or Z direction. When people talk about DWI, usually they just combine these three images and take an average, get this. But if we can really track the direction information, we can get more information that's useful for pathology. Water molecule diffuse preferentially along spatial direction. In brain, it's the axon fiber direction. So we want to study the direction of diffusion, which can reflect the structure of organ. If at any one pixel, if the motion are the same, has the same preference along X, Y, or Z, then the diffusion tensor we get, they have three eigenvector, and these three eigenvector, they are the same. No, eigenvalue, they are the same. That means it's isotropic motion. But if it prefer to move along this direction, then the eigenvector, one eigenvector lambda 1, eigenvalue lambda 1 is much bigger than the other two. This corresponding eigenvector is the main direction it wants to go. But if we acquire in any direction, then it might not align well with the direction of diffusion. So the tensor will be pretty complicated, but this type of thing can be converted to this type with the rotation. When we get the diffusion tensor, we can do different type of manipulation. As in the example I showed, they can just do average. We get mean diffusivity, or we can measure the ratio or the variance. That's a very brief introduction about DTI. So summarize what we talk about in diffusion-weighted MRI today. In diffusion-weighted MRI, we acquire images using diffusion-weighted sequence. It's diffusion gradients added to a spin echo EPI sequence. Then the signal will decay, and this signal decay depends on operator parameter B and the diffusion characteristic of tissue. If we have smaller B, then we have stronger signal. If we have larger B, we have decreased the signal, but the contrast is better. And different tissue have different diffusivity. Most time, lesion have restricted diffusion, and they have stronger signal in DWI. In DWI, they have both diffusion weighting and the T2 weighting. Then we post-process DWI and get ADC map. ADC map contain only the diffusion weighting information and eliminate the T2 weighting. So ADC can be used to differentiate T2 shine through. DWI and APC can be used in cancer management. It can be used to detect lesion with restricted diffusion. Lesion with restricted diffusion, they look bright in DWI. and can be detected. And it looked dark in ADC, so it's confirmed. If some tissue is bright in DWI, it can be T2 shine through by confirmed from ADC it's bright. The characterization of lesion is because different type of lesion have different ADC value, and we can do the characterization. DWI can also be DWI and ADC can be used to detect tumor residue from post-treatment change. Because this one has restricted diffusion and this one does not have restricted diffusion. And it can be used early detection or prediction of treatment response. This is the direction of research. DTI is a matrix version of DWI tracking the direction information. That's all.
Thank you very much.
Thank you. Yep, thank you. I can just, let me stop the recording, sorry.